You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
When every decision matters, you need trusted medical intelligence. Medscape AI synthesizes peer-reviewed evidence and Medscape's expert-validated content in seconds, delivering clinically verified answers you can trust. Join over 13 million Medscape members on the world's leading platform for clinicians. Start using Medscape AI on the web or in the Medscape app. Medscape AI, trusted medical intelligence.
Hi everyone, this is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for May 29th, 2026. This week, a potential lifelong treatment for high LDL cholesterol, a Vesalius trial subanalysis, Tirzepatide beats semaglutide again, arrhythmia burden in cardiac amyloidosis, and a lipid guideline rebuttal. I would like to first thank the Danish Cardiac Society for inviting me here to speak in Nyborg, which I mispronounced last week as Nyborg. I know that I say it often, but I love Denmark. As I record here in my hotel room overlooking the sea, I had to actually close the window because of the sea noises in the background. It's no wonder that Danes are rated as one of the happiest people. This country is beautiful. Now, it was imposing to speak to more than 300 Danish cardiologists because I know that they have such a strong foundation in scientific appraisal of evidence. Yet, to my surprise, there are still a handful of left atrial appendage closure enthusiasts here. Of course, I showed them my appendage closure slides and tried to persuade them. I also personally thank Dr. Jens Brock Johansen for taking me on an epic 109-kilometer journey to the northern tip of Denmark. And today I ride with Soren Nielsen, and I thank you all for the great adventures on the bike. The first topic today is a potential permanent lipid lowering therapy. New England Journal of Medicine published on Monday an amazing paper with 35 patients who had familial hypercholesterolemia who underwent a base editing therapy designed to durably inactivate PCSK9 protein in the liver. The basic science here is beautiful. It's long been known that loss of function variants in the gene pro-protein convertase subtilsin kexin type 9 PCSK9 confer lifelong low levels of blood PCSK9 protein and low-density lipoprotein L cholesterol without apparent adverse effects. People with this genetic signature also have markedly lower rates of atherosclerotic coronary disease. Indeed, PCSK9 is now a well-established way to reduce major adverse cardiac events. In addition, these drugs appear to be safe from off-target effects, at least in shorter-term trials of 2 to 5 years. Another observation from genetic studies is that the cumulative exposure to low LDL cholesterol also seems important. Yet the logistical problem for prevention of heart disease is that many patients do not take lipid-lowering therapy, or when they do not adhere to it. Observational studies have reported discontinuation rates of 30 to 50%. So Dr. Sek Kethorason and his team have been working on a base editing infusion that mimics favorable PCSK9 gene variants. The way it works, Verve 102 consists of two drug substances, a messenger RNA encoding for an adenine base editor protein, and a guide RNA targeting PCSK9. These two substances are encapsulated in a lipid nanoparticle delivery system that incorporates an N-acetylgalactosamine targeting ligand to enhance delivery to hepatocytes. The guide RNA targets a splice site at the 5' end of intron 1 of PCSK9. Altering the splice site with a single DNA base pair substitution then enables a read-through of a stop codon that prevents translation and expression of PCSK9 protein in the liver. There is a really nice figure in a New England Journal of Medicine paper. Now, included patients had to have the diagnosis of heterozygous familial hypercholesterolemia or premature coronary artery disease, which was defined as disease before age 55 in men or before age 65 in women. Participants also had to have a fasting LDL cholesterol level of at least 70 milligrams per deciliter, while receiving the maximum tolerated dose of oral lipid-lowering therapy, a statin usually with or without ezetimibe. Infusions of varying doses took 4 hours, and they used pre-treatment steroids and antihistamines. Patients underwent inpatient observation for at least 2 days and had daily clinical and laboratory assessments through day 4. Patients were on average 52 years old. 29 of the 35 had FH. Mean LDL cholesterol was 129 milligrams per deciliter, and most of these patients were on high-potency statins. So as far as safety goes, 1 in 5 patients had minor infusion events. These were just a few patients with minor liver enzyme elevations, and these were mostly transient. And the results: this infusion worked. Circulating levels of PCSK9 were lower, and the lowering effect was dose-dependent. LDL cholesterol also dropped, ranging from 44% to 62% lower based on the dosage. The effective PCSK9 reduction and LDL cholesterol reduction were durable up to a year. So my comments. You'd have to put this in the science is amazing category, honestly. This is presumably permanent treatment of hypercholesterolemia. Now, whether these patients have to remain on statins as well remains to be seen. In the 1 milligram per kilogram dose of this infusion, the mean reduction was 78 milligrams per deciliter. This would be estimated to reduce atherosclerotic CV deaths or CV events by 50% for patients with FH. This represents an iteration on a previous attempt from this company. The previous attempt was associated with serious liver inflammation and low platelets. The team made changes in the lipid nanoparticle, and this attempt looked to be safer. Second, the degree of PCSK9 inhibition seems similar to that seen with the sub-Q injections and consistent with near-complete suppression of at least hepatically produced PCSK9 protein. Now, the authors caution that hepatocytes turn over every 200 to 300 days, so there needs to be longer-term follow-up to assess durability of this effect. And of course, there are plenty of limitations. This is a phase 1 study. In other words, it's mile 2 of a marathon. Efficacy and safety are major worries, right? For me, the risk of off-targeting gene editing is very concerning. What effects will there be in 10, 20 years? Recall that the alternative is a fully reversible therapy with either a sub-Q injection or soon a tablet. But I say congratulations to Sek Kathiresan and his team on this potential breakthrough. Much remains to be known safety-wise, but this is a remarkable achievement in biology. Okay, next topic is a Vesalius substudy on PCSK9 use in patients with previous PCI. Circulation has published a subgroup analysis from the main Vesalius trial of evolocumab versus placebo in 12,000 patients with ASCVD or diabetes, but without an MI previously. New England Journal of Medicine published the main Vesalius study in 2025, and this was notable because the 2 previous PCSK9 trials had been done in patients who had an ACS event. Odyssey Outcomes was alirocumab in patients with ACS, and Fourier was evolocumab in patients with a previous MI, stroke, or PAD. Vesalius included lower-risk patients, these without MI, but with CAD or PAD, or cardiovascular disease of some sort. Patients in Vesalius also had to have an LDL cholesterol greater than 90. The main results of the main Vesalius trial was a statistically significant 25% reduction in a 3-point MACE endpoint of coronary death, MI, or stroke. The absolute event rates were 6.2% versus 8.0%. That's a 1.8% absolute risk reduction, an NNT of 55. Now, as it was in all of the PCSK9 trials, the reduction was in non-fatal events. In Vesalius, there was no reduction in coronary death or all-cause death. So the trial was positive, but the risk reduction is modest. And that is not surprising because if baseline risk was lower, you'd expect less absolute risk reduction. The circulation reanalysis focused on patients in the main trial who had had PCI. Importantly, the main trial enrolled 12,000 patients. That's the power that it took to sort out event rates. You need a lot of patients when drugs have small effect sizes. Now, the subgroup of patients who had had PCI is even smaller. It's about 3,600 patients, or 30% of the main trial had undergone PCI. Now the question is effect size in these patients versus the 70% who had not had PCI. In both the placebo and the evolocumab arm, patients who had had prior PCI had higher rates of both primary endpoints, the 3 and 4-point MACE. I'll focus on the more robust 3-point MACE, which is coronary death, MI, and stroke. Now, you'd expect these patients to have higher absolute rates because if you have a PCI, that's got to be a marker for more significant disease. In patients with prior PCI, evolocumab reduced the risk of 3-point MACE by 30%, 7.0 versus 9.5%. That's a hazard ratio of 0.70. Confidence intervals were significant, 0.56 to 0.89, p-value 0.004, and that's compared to placebo. Components of the endpoint were mostly driven by MI, but coronary death was directionally consistent. Here were the numbers. For coronary death, the hazard ratio was 0.69. Confidence intervals were 0.43 to 1.09. For MI, the hazard was 0.5. The confidence interval was 0.36 to 0.70. And for stroke, it was 1.06, but there were very few strokes in wide confidence intervals. Now, rates of CV death and all-cause death were also lower, but these are reported with nominal p-values due to multiple testing. So my comments. Now, much is being made about this subgroup analysis. I've seen it on social media, and there's just a lot of press about it. But I don't find it that shocking at all, right? The main reduction of the 3-point MACE in the main trial was 25%. In this higher risk group of patients who had had PCI, it was 30%. You'd expect that, especially since patients in Vesalius had to have an LDL cholesterol greater than 90, and the actual LDL cholesterol was as high as 116 milligrams per deciliter. So no surprises. In patients who have established disease, especially previous PCI, we would all agree that you'd want an LDL cholesterol lower than 116. PCSK9 drugs achieve that. But so does higher potency statins, or so would statins plus ezetimibe probably also achieve that. Now, despite CV death and all-cause death reductions in this subgroup analysis meeting significant levels, that is, that when you look at the upper bound, it's less than 1.0, I would not say that this drug reduces death in this subgroup, and that's because there are simply too many comparisons and the subgroup is too small. Recall that trials are powered for the entire group. When you slice up groups of patients within a main trial, you lose power and the risk of false positive findings simply by chance is greater. For instance, like the astrologic sign analysis in ISIS-2. That said, I would propose that this study simply shows that patients with previous PCI benefit to a similar degree than those with CAD who have not had PCI, like the patients that were enrolled in Vesalius. All right, next topic is Tirzepatide looking to be the best GLP-1 agonist again. The Annals of Internal Medicine has published a study called Surpass Early. This is Tirzepatide versus intensified conventional care in patients who have obesity and type 2 diabetes. The Lilly-sponsored trial was carried out in 78 sites in 10 countries, and the report this week were the 2-year results of a planned 4-year trial. This was nearly 800 patients were randomized to Tirzepatide, with dose escalation getting to the goal of 15 milligrams, or intensified conventional care with a goal of normal glycemia. Now, the primary endpoint was a change in hemoglobin A1C from baseline to 2 years. Initial testing was with non-inferiority. Secondary objectives included superiority test of the change in hemoglobin A1C, as well as weight and waist circumference. These patients were young, 53 years old, nearly half were female, and the BMI was 35 at baseline. The starting trial hemoglobin A1C was elevated at 7.8, and most of these patients had diabetes for about 2.5 years. Now, before I tell you the results, notable was that at 2 years, 85% of patients in the intensified conventional care arm were on GLP-1 agonist, with 74% on semaglutide and 12% on dualoglutide. SGLT2 inhibitors were used in 17% and in much smaller numbers on sulfonylureas, insulin, and DPP-4 drugs. Most patients, 88%, were on just one glucose-lowering agent alongside metformin, with only 10% on 2 and only 1% on 3. So in essence, really, and I didn't realize this when I first looked at the trial, this was predominantly a semaglutide versus tirzepatide comparison. So first, glycemic control, the hemoglobin A1C. Tirzepatide reduced the hemoglobin A1C by 1.99 percentage points versus 1.32 with intensified conventional care. Mean hemoglobin A1C landed at 5.5% with tirzepatide versus 6.35 with conventional care. 60% of tirzepatide patients reached normal glycemia, defined as a hemoglobin A1C less than 5.7, versus only 24% with conventional care. That's 60% versus 24%. It's a substantial difference. Weight loss, as you'd expect, tirzepatide decreased the weight by 13.8 kilograms versus 5.9 kilograms in the conventional care. 44% of tirzepatide patients lost more than 15% of their body weight versus just 12% with conventional care. Waist circumference, very same numbers, 11.6 centimeters reduction versus 5.4. Other metabolic benefits, and I'll comment on this later, there were greater improvements in triglycerides, HDL, blood pressure, beta cell function, and insulin sensitivity with tirzepatide versus the conventional care, which again was mostly semaglutide. Side effects were mostly GI, as you'd expect. No severe hypoglycemia was noted in either group. There was one confirmed case of pancreatitis in the tirzepatide group, and treatment continuation due to side effects was low but higher with tirzepatide, 4.5% versus 0.3%. So comments. Even though this was a predominantly diabetes study, I highlight it because I am becoming increasingly impressed with these drugs and their ability to improve metabolic profiles, such as hemoglobin A1C, but also lipids, triglycerides, even hypertension. For instance, I'm increasingly seeing in my AFib clinic patients on these drugs who A, lose weight, of course, and B, massively improve their lipid parameters. One patient stands out, for instance. This is a 65-year-old man. He's not that heavy at 28 BMI, took GLP-1s, and dropped his abnormal triglycerides and LDL cholesterol such that both are now in the normal range without lipid-lowering therapy. He had to stop his valsartan due to low blood pressure with his 8-kilogram weight loss. So then, just playing around with the PCE, pool cohort equation, and the ASCVD risk, his risk went from 10% to 6.6%. So he went from statin eligible or statin indicated to below that 7.5% threshold. AFib episodes, in case you're wondering, decreased. Now, if you're going to use GLP-1s, and I think it is time for cardiologists to step up and start using these drugs, we should probably use tirzepatide due to its superiority over semaglutide for weight loss, and in this study, glycemic parameters. And this isn't the only study showing tirzepatide as more potent. The SURPASS early study reconfirms the SURMOUNT-5 trial published in New England Journal of Medicine in 2025, and I covered that then. SURMOUNT-5 found that tirzepatide was better than semaglutide for weight loss. The weight loss was 6% greater with tirzepatide. Now, one question that I hear is what is causing these improvements? Whether their improved metabolic factors occur because of weight loss or some other weight loss independent mechanism does not matter that much to me. That patients can lower their ASCVD risk this much makes me wonder whether GLP-1s will become a more important drug class than, for instance, statins. I mean, it's a long way to prove that because statin drugs have more than 175,000 patients randomized in trials. But the changes I'm seeing with these drugs are amazing. They're stunning. Now, I'm not saying we should be treating young people with simple, uncomplicated overweight or obesity, but adults like these patients enrolled in the trials, these patients are heading for trouble soon. I consider a patient in his 50s with type 2 diabetes, hypertension, sleep apnea, obesity. This person has a serious illness and they're going to get in trouble. And these drugs seem to treat the serious illness, and I think it's a good thing. All right, next topic, arrhythmias in cardiac amyloidosis. Like you, I see more patients with cardiac amyloidosis. Whether this is due to increased surveillance or increased disease incidence, I don't think is well sorted out, but it sort of doesn't matter. My overall impression is that these patients require lots of effort in surveillance and treatment. Jack has published a small but very nice paper from the UK National Amyloidosis Center, and they implanted loop recorders, ILRs, in 110 treatment-naive patients with newly diagnosed cardiac amyloidosis. They followed these patients for 36 months. Now, while loop recorders admittedly have very marginal value in real-world clinical practice, in fact, I learned this week that in the cost-constrained Danish healthcare system, ILRs are rarely used. But in the profit-driven U.S. system, ILRs are like cash machines. Now, people ask, I do use ILRs sparingly, mostly in patients with infrequent but severe syncope, and in the rare patient with AF who has post-conversion pauses, whom we ablate, and then we want to prove that the AFib is gone, because if the AFib is gone, we know that the pauses will go away as well. Now, ILR use, in my opinion, in post-stroke patients is wildly overused. In the U.S., it's especially bad because not only is it lucrative to implant these, we get reimbursed quite well, but patients get a recurring download bill every 30 days. That said, the ILR can have great use in research. The many studies coming from the loop investigators, for instance, have shed great light on the natural history of short-duration atrial fibrillation. This study, which the authors named Excalibur from the UK group, they simply put in ILRs in patients with cardiac amyloidosis to see what happens. In some, my friends, a lot happened, as you'd expect with this awful infiltrative disease. Here's the breakdown of the study as follows. Of the 110 patients, they had 43 patients with wild-type ATTR, they had 20 variant ATTRs, and then they had 47 light-chain AL cardiac amyloidosis patients. And they found three main arrhythmia types. Bradyarrhythmias first. 17% of the patients developed a class 1 pacemaker indication, roughly twice the rate reported in prior retrospective studies. This included complete AV block in 42%, Mobitz 2 in 26%, and symptomatic Saxena syndrome in 21%. These were significantly more common in ATTR cardiac amyloid, 24%, versus 9% in AL cardiac amyloid. And they were associated with higher myocardial amyloid burden, and that was measured by MRI. As far as atrial fibrillation goes, new onset atrial fibrillation occurred in 28% of patients who had, without prior AF. Again, more frequent in ATTR cardiomyopathy, 50% versus AL cardiac amyloid, 12%. There were strong correlations with the degree of amyloid infiltration. Also interesting was that all but 2 patients were asymptomatic. All patients were started on anticoagulation, and no strokes occurred during the time of this study. Ventricular arrhythmias. Sustained ventricular arrhythmias occurred exclusively in AL cardiac amyloid, 6.4%, and that at a stage of moderate rather than advanced amyloid burden. Non-sustained VT was common. It occurred in 12 patients total. That's 11% of the overall population. The NSVT incidence was nearly the same in the 3 subtypes of cardiac amyloid. None of the patients were symptomatic during these events. And importantly, none of the NSVT patients progressed to develop sustained VT. What about terminal rhythms? All 10 ATTR cardiomyopathy deaths showed pulseless electrical activity. Pulseless electrical activity was also the most common terminal rhythm in AL cardiac amyloidosis. However, 2 patients did have VTVF as a terminal rhythm in that type of cardiac amyloid. So my comments. Now, studies like this don't make the New England Journal of Medicine. They don't win you Nobel Prizes, but I find this extremely useful natural history information. It's a good study, and it's important, and it informs us. There is a lot of heart block in these patients. Now, we can warn patients to pay attention. This group put in devices for asymptomatic patients, and we don't usually put in pacemakers for asymptomatic bradycardia, but I doubt a patient with heart block with amyloid would stay asymptomatic for very long. Now, as for the AF detection, we know that screening in a general older population, like those in the LOOP trial, did not end up reducing stroke, but I agree with the use of anticoagulation in these much higher risk patients. Now, whether we should have a screening study, perhaps with smart watches or smartphone ECGs, in this population of patients with cardiac amyloid is something to consider because the AF rate was so high. And of course, the stroke risk would be high in these patients. I also find it fascinating that none of the deaths in the ATTR group were due to VT, and none of the SVT progressed to malignant VT. Now, I don't want to make too strong conclusions from this 110 patient study, but it's interesting, isn't it? And it indeed is one strong data point. Note that ILRs are very useful as research tools. They are always on, and they're very good at arrhythmia detection. Another clinical implication from the lack of VT-VF as terminal events is the resistance to put in ICDs in these patients. Cardiac amyloid, I think, represents a classic scenario where progression of disease is likely the cause of death and not a stochastic type cardiac arrest. So please, my friends, watch closely for heart block, have a low threshold for anticoagulation, but resist the urge to place ICDs in these patients, especially if you're using non-sustained VT as a marker. All right, the last topic today is about lipid guidelines. As you all know, I wrote a critique of the new ACC and AHA guidelines. My main points were that the guidelines were too complex and they were too devoid of RCT level data, and that rendered many of the class 1 indications and class 1 indications are things that you should do, or if you don't do, you're in trouble. These were poorly supported with evidence. I also struggled with the declaration that the PREVENT score is better than the simple PCE, and I felt that experts with intellectual and financial dualities of interest should not be writing guidelines. The disclosure part is not enough in my opinion. This document had to have huge lists of conflict of interest, not only of the authors actually, but also of the peer reviewers. I just ask you, for instance, if a person's entire research area is in imaging, and he or she has a financial stake in an imaging company, what do you think this person is going to say about imaging in the guideline? Are they going to say that there's no strong data and we should wait to use imaging? It's not likely. Anyways, lead author Roger Blumenthal and some of his co-authors have written a lengthy rebuttal, and Medscape has published it. And as it is my rule, I do not comment on their rebuttal. You can read their rebuttal and decide for yourself. I will say that they did not change my mind, but you all decide by reading the article and see what you think. So until next week, this is John Mandrola from the heart.org Medscape Cardiology. And remember, if you like this podcast, please take the time to write us a review. If you have a question about something I said or you disagree, send me a note and we can do listener feedback.
You're listening to This Week in Cardiology from the heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.